Hi, I'm Austin Creel, and I'm going to be testing the reflex of the quads, the spasticity of the elbow flexors, and explaining the lateral vestibulospinal tract today. To test the reflex of the quadriceps tendon, you want the patient in the sitting position with their feet elevated off the floor, free to move about. You want to stand on the lateral side, so that way you don't get kicked if there is extreme spasticity. The spasticity scale, and I actually have it wrote down here, or not spasticity, excuse me, reflex scale, is on from 0 to 5, and you start with about a 2 plus is considered normal. Then you have a 3 plus, a 4 plus, and a 5 plus, which is sustained clonus, and you go down to a 1 plus and down to 0 where there's no response. To actually test the reflex of the quadriceps tendon, like I said, you want their feet open to swing, and you're going to be tapping with a reflex hammer on the quadriceps tendon, which actually inserts into the tibial tuberosity. So in between the patella and the tibial tuberosity is where we're going to be. And so we want to elicit a normal response, which is normally two to three little movements of the reflex response. So, and you want to have your hand right above the knee joint where the quadriceps tendon comes together from the muscles, and where you can also palpate a reaction if you don't actually see anything visible. So what we'll do is we'll take our reflex hammer, and we're going to find it right here on the quadriceps tendon and hit that. Okay. Okay, we want to compare that to the other side. Okay, getting a good reaction first and then a little bounce or two. And it's the same on both sides, and it's very minimal. So we'd say she's normal on both sides. Now, to test the spasticity of the elbow flexors, we're going to use the modified Ashworth scale. And from research that I saw, the modified Ashworth scale is recommended to do in supine because we don't want to increase any tone from positioning, and tension from the body in different positions can elicit tone, and you won't get the same response. So what we'll do is I'll have her in supine, and spasticity is velocity dependent, so we want to move the joint that we're testing and the muscles that we're testing through how they would normally move at the speed of gravity. In this position and in this test, you want to do it for a maximum of 3 times, but no more, because you don't want the short-term effect impacting the score. So to test the elbow flexors, the start position, we'll start in a fully flexed position in forearm neutral, and I'm going to stabilize just proximal to the elbow joint and also on the dorsal side of the forearm at the wrist. And then we'll move into full extension and then back to full flexion to see if we elicit any spasticity, and we'll check that on both sides as well. So I asked Julie here to relax, and I'm going to, like I said, proximal to the elbow joint and on the dorsal side of the wrist just above the joint there. We're going to start in the fully flexed position, and then we'll move normally here from fully flexed to fully extended. Okay, and you want to move about what she would normally fall. Let your arm fall, Julie. Normally what you'd fall against gravity, so you want to move in that, and so we're not getting any kind of resistance. If we saw some spasticity, we might get some resistance here, or none at all if she was completely flaccid. Okay, so we just have normal resistance from the soft tissue muscle that she has, which is very minimal resistance. It's just soft tissue. Same thing on this side. Just proximal to the elbow joint, dorsal side of the forearm here, and we're going to go and start in full flex, go to full extension, full flex, full extension, full flex, full extension. Okay, and so she's normal there. Thanks, Julie. What we would normally see in that instance, according to the modified Ashworth scale, 0 on the modified Ashworth scale would be there's no increase in the tone where she would have a flaccid muscle. 1 is there'd be a slight increase in tone, kind of a catch and release, having a little bit of minimal resistance at the end range of motion, and that's kind of considered hypertonia. Then you have a 1 plus, which is a slight increase in tone again with the catch, and you followed by minimal resistance in the remainder of the range of motion. In a 2, you have a more marked increase in tone through the rest of the range of motion is normal. Number 3, the considerable increase in tone. The passive movement is difficult, and that's mild hypertonia. And then a 4 would be you're affected in in part rigid inflection or extension, and that's severe hypertonia. Again, that was a testing for the spasticity of the elbow flexors. I had the lateral vestibulospinal tract, and what it does is the lateral vestibular nuclei, which are located on the border of the pons and the medulla, they respond to gravity information from the vestibular apparatus that's in the pons and the medulla. Those pathways from the lateral vestibular nuclei, those lateral vestibulospinal tracts, facilitate the lower motor neurons to the extensors while inhibiting the lower motor neurons to the flexors. The fibers in this tract are uncrossed, and they descend the entire length of the spinal cord. They terminate on the interneurons that activate the motor neurons that are innervating the extensor muscles of the trunk and the ipsilateral limb. These impulses from the spinal cord, they facilitate the ipsilateral extensor motor neurons and their associated gamma motor neurons, which increase the extensor muscle tone. The main function of the lateral vestibulospinal tract is to control the muscles that maintain upright posture and balance. When a person is upright, the lateral vestibulospinal tracts are continuously active. They're active to maintain the center of gravity over someone's base of support, which they respond to the slightest destabilization, again affecting the postural muscles. So again, that was the reflex of the quadriceps tendon, quadriceps muscles, the spasticity of the elbow flexors, and a brief explanation of the lateral vestibulospinal tract. Thanks.